Good morning, everybody. Thanks for being here. So today's session, as you know, is on bridging gaps, AI's role in addressing health disparities. We have a number of wonderful speakers today who will explore how AI can be leveraged to address health disparities. We'll cover technological, ethical, policy, and social dimensions that impact its effectiveness and implementation. I'm moderating the session. My name is Deepshika Shana. I'm a critical care physician at Duke, and I do some work on bias and risk prediction in the ICU. I think we're starting with, are you going first?
Hi, everyone. Eric Laber. I'm in the stats department, in the biostat department, and I work in data-driven decision-making.
Hi, everyone. I'm Jana Scheichborg, and I'm an associate research professor in the Social Science Research Institute.
Hi, I'm Ben Goldstein. I'm professor in statistics and mathematics, and I serve as division chief for translational outlook for the year, and still as director of data science for Duke AI Health.
Morning, I'm Michael Jerry, I'm associate professor at the University School of Nursing. I'm also the AI Health Equities Health for the health system.
And just for the audience, in terms of structure of the session, we'll be in here for about the next 70 minutes. The speakers will take about 30 minutes to give some brief talks, so we'll have plenty of time at the end for a panel discussion. And we encourage you to formulate questions and ask them at the end. Would you like to get started, Eric?
Oh, sure. That's good. Really, the slides I prepared are just an introduction to the kind of things that I think about, which I thought might be useful as the discussion gets going. So why am I here? I think maybe that's a little bit of the odd duck compared to the rest of the panel. So I'm a statistician. I've been here at Duke for about 5 years or 4.5 years. I was at NC State for 10 years before that. I work in how to automate decision-making in precision health. So in precision medicine and public health. I have this other part of my life where I also do data-driven decision-making in robotics and retail, which I think is going to be particularly relevant when we talk about things like scale and cost, because that's the focus in a lot of those types of applications. And I think healthcare has something to learn there. So I brought it up. And related to that, I've worked with industry my whole career. So I spend 20% of my time at Amazon running a research group on decision-making in robotics and in retail, and thinking about how do we scale things, automate decision-making in an adaptive manner. And we worry about some of the same things we worry about in health, although you could argue that maybe the stakes are a bit different. So I just wanted to give a very brief introduction to the kinds of things that I'm thinking about and how these sort of create questions about disparity and fairness and so on. So one project we've been working on for maybe 8 years is how to better tailor behavioral and diet exercise interventions with type 1 diabetes who are obese. So changing diet, exercise, and diabetes is complicated because as you change those behaviors, you change glucose, right? And it can have very unpleasant feedback mechanism. And so we have this app called Hydra that tries to learn the unique biology of each patient and then give them better recommendations for insulin, diet, and exercise. The challenge here is how do you make those recommendations while ensuring that patients are safe, right? And not just safe in an aggregate way, right? And so average safety is not enough. It needs to be each patient is safe. Then how do you also guarantee you're going to learn, right? So is it even possible to learn an optimal strategy for each patient if you put strict guardrails on safety, right? And so how do you mathematize those things? How do you monitor those things as they're running, right? How do you detect that maybe some subgroup is unsafe while the population sort of as aggregate is safe and so on? So those are the kind of questions we think about with this app. In the public health space, we think about how do we use AI to better sample hidden and hard-to-reach populations. So for those who are unfamiliar, network sampling is a very common tool with these types of populations. So things like, or in populations like injection drug users, sex workers, non-utilizers in a healthcare system, you don't have a sampling frame. There's no list you can just randomly sample from. So to reach these individuals, you use various network-based techniques where you might get a sample of people in this population, then you ask them to recruit some of their friends, ask their friends to recruit their friends, and so on. And you sort of spider through the population. Okay? And the way this is done is you give them coupons which have incentives and tell them it's important for you to participate in the study, or maybe you get a financial reward for participating. And so what this looks like in a cartoon is you start with someone, you ask them to recruit some of their friends, and the different arrows here represent different coupon, say maybe wording or values or calls to action. And so the gray person recruits 3 of their friends who are also in this population. They recruit some of their friends and their friends and their friends and their friends, and eventually you end up with a sample. It's not a simple random sample. It's a complicated mess from a statistical perspective. But what we're interested in is how to generate samples like this that are as effective as possible by learning as we go. And it turns out if you adapt the incentives as you go, it's much more effective. Orders of magnitude more effective. So what does that mean? You can change the number of coupons you give certain people because they may have more friends and more friends in the population you care about. Or maybe you change the incentive because the incentive is going to matter more for some than others. Or you change the wording. It's important for you to participate because it's going to help your community. Or it's going to be better for your health. Or it's going to affect policy. Right? So it has this great impact, but this algorithm is running on its own and it's learning as it's going. So how do you prevent it from doing things like, well, I can give people with less money less incentive? That's maybe not so good, right? Or there are certain people who don't trust the healthcare system and they don't want to engage, and it's hard to get them to engage, so I'll spend our resources somewhere else, right? And so those people are further disconnected from the data that are being collected and the policies that are being implemented. And so we can sort of anticipate some of these, but there's all sorts that we don't anticipate that could be happening. And how do we know when these are happening? Right? So thinking about these kind of algorithmic designs is something that has come up in our work. And then finally, adaptive. This is a more classic example. The I-SPY 2+ trial is a platform cancer trial where you're trying to adapt treatment randomizations to individuals, as well as changing the pool of treatments over time and changing the sequences of treatment. And the kind of things that you have to think about in these settings are, well, how do I balance in trial versus out of trial? It's a very old problem, right? Benefit those in the trial versus the information you generate, but also things like agility versus certainty. So I can graduate a treatment now and start treating people with that new therapy, or I can wait and be more certain, right? And so what's the trade-off there? And there's a certain limited time window, and when do I add new treatments, when do I take treatments out, and so on. So I wanted to give this sort of, we're running into, I don't want to talk about this other stuff. Yeah, okay, well, I think there's extra slides somehow, which I'm not going to get into. But all I wanted to say to wrap this up is these are all sort of small problems that are being addressed in a very bespoke way by people who are thinking about these specific trade-offs. And when we go to scale, we talk about AI, all of this gets exacerbated, right? All of it gets hidden, and you start thinking about going to an entire healthcare system or a nationwide scale, and it becomes very hard to detect these trade-offs and then even balance them if you can find them, right? So I think I'm going to stop there and pass it off to whoever is next. Yeah. Sure.
All right, so you might think you're the odd duck out, but we'll compete at that and we'll see. So I think the best, and I don't have slides, so it's actually told we weren't supposed to have slides, so forgive me. Hopefully I won't be too wordy. So I think the best way to understand me is that I'm a neuroscientist. For those who are in the medical field, a systems neuroscientist and a cognitive neuroscientist who's been adopted by data scientists and computer scientists. And as some context for kind of the way kind of the things that will influence me in this conversation, there are three main ways that I interact with AI. One is just as a user. So I've been using AI for decades now in my own research. We saw AI broadly construed, which includes many types of machine learning, whether that be to identify networks in the brain, whether that be as part of a brain-machine interface for psychiatric disease, or more recently to identify aspects of social interaction and what makes us feel socially connected, and as ways to screen for social disconnection syndromes, like in autism or things that can happen after traumatic brain injury. So I'm a user, and I've seen many of the things AI can do, but also can see many of its challenges, and I've grappled with, actually writing code that has to use AI systems. The second way I interact with AI is actually as an AI developer. So my specialty in neuroscience is social intelligence, so specifically human social intelligence. What makes humans social? What allows us to function most socially in socially beneficial ways and interact as communities that benefit each other. And within that, my kind of real specialty is in moral decision making and moral intelligence. So I spend a lot of time thinking about the similarities and differences between human social and moral intelligence and artificial social and moral intelligence, especially these days with our current systems. And also work on ways to integrate and leverage what we know about how the human brain makes social and moral decisions, and how we can kind of integrate that into AI systems so that AI systems could behave in ways that we find more socially and morally acceptable. So I also work on kind of the deep nitty-gritty of how do we develop algorithms and AI systems. The third way that I interact with it, which overlaps a little with what you just said, is as a AI educator. So I started my time at Duke in the neurobiology and the psychiatry departments, but I moved to the Social Science Research Institute when we were starting the new, at that time, Master in Interdisciplinary Data Science program here at Duke. So I was deeply involved in setting up the curriculum for that. I was the first faculty director, then the director before handing it over to the current director. And so I've spent a lot of time thinking about these are master's students who usually leave academia, and these are the ones who are often implementing and deploying systems, including in healthcare related domains, but outside of kind of our university system. So I think a lot about what do people outside of, say, a place like Duke need to be able to implement AI ethically, and what are their constraints and what are their incentives. And so that will color a lot about kind of how I think about things. So part of the reason that I'm sharing that background is to make clear that I'm an AI enthusiast. I've been using AI for a long time. I also went to undergrad in a place that at least claims that it was the birthplace of AI. So it's something I think should be very clear. I really advocate for it, and I think it's our moral responsibility to use it in all the tremendous ways it can be used to benefit society. But the role I often play in a panel like this is the one who's advocating for a very balanced view. Because while AI can have tremendous benefits that we must pursue, it also can have tremendous harms. And they're such tremendous harms that it's really something we all have to be aware of and be working towards and be constantly trying to mitigate. And I feel so strongly about this balanced view that I wrote a book called Moral AI and How Do We Get There that came out last year. And I'd love for the Duke community to get involved in the Moral AI movement and give us feedback on that book. And it's also, I should say, it's written for anyone with any background. It's supposed to get people with any background up to speed on kind of what are the main ethical issues that AI poses and what are some practical ways we can start to address it. But there's a whole chapter in that book on fairness and how AI can impact fairness and can exasperate aspects of bias and amplify bias. It can also be used, and I hope this will come out in our discussion, kind of the more nuanced discussions, can also be used to mitigate bias. And there are technical tools and social tools, and many other types of tools that people are working on and making a lot of progress with, that if we can figure out what we actually mean by something like equitable, a term called equitable, and we can define it, then we can actually adapt our AI algorithms to make it more likely that those AI algorithms will act in a way that's consistent with that goal. Now, I'm not only, if you read the book, you'll see technology is one thing we talk about, but there are many other pieces. Today, I'll just mention some of the technical work, but I want to make it clear I don't think that addressing AI fairness or equity is just a technical problem. But with that in mind, I will mention, I think probably we'll hear a lot about inequity and ways that AI algorithms can be unfair and ways we can address that in our discussion and maybe from the other panelists. So I actually want to call attention to an aspect that I think is not given as much attention. So since 2016, my group has been working on what we call moral AI. How would you design AI systems so that they can reflect a community's values and behave in ways that are at least more consistent with the community's values than if you don't pay attention to those things? And fairness and equity is one of those, a value you might care about and that we work on. And people are making progress, so you should have some optimism. But it doesn't matter how good your algorithms are and how fair or equitable they are. If the human who eventually has to decide what to do about the recommendation from the AI system is biased, or if they don't make good decisions, it won't matter what the AI says. So especially in a place like healthcare, where many people advocate that or say that AI should not be the ultimate decision maker. It should always be a human expert who decides whether or not to accept an AI's recommendation. You may not agree with that, but many people feel that, especially in a domain like healthcare, that should be the case. Then that means that it's ultimately the human who will determine whether or not an equitable outcome is achieved. And so one of the things we really need to think about is how can we make humans better moral decision makers in those contexts? Because one of the things we're learning over the past 2 years is that we often AI can actually make us worse decision makers. We can kind of default to what it says, and it's actually the best of us that lose the most skills with AI. It's kind of those who are not underperforming kind of get their skills raised up, and those who are the highest performing often get their skills raised down. And that happens in medical decision making as well. So we really have to think about that. And so one of the things that some of the technologies we've been thinking about are how can AI be used to help us humans become more reliable, consistent, principled decision makers, and specifically moral decision makers, and in medical contexts. So I'll just tell you about two of the ways that we're working on now, but I mostly wanted to call attention to this concept. The first one actually we fell upon by accident. And let me just kind of introduce it by saying, I think many people want to think about morality or ethics as something that's just on or off. You're either a good person or you're a bad person, and if you're a good person, you're generally going to do good things. But that's actually not the way to think about it. Almost all of us are always trying to do our best. We have good intentions, but we're human and we make mistakes all the time. But even more than that, making good ethical decisions takes practice, a lot of it. And unfortunately, what we don't realize is most of that practice comes from real life. And when we make mistakes in real life, people are harmed. And when you have to make really hard moral decisions, we don't get practice with that. We're just thrown into it. And the same thing happens in medical decision making. So what if AI could be used to help give us that practice? What if it could give us a safe place where we could figure out what it is we actually think is right or wrong, what kind of model or process, decision-making process we want to use in an ideal setting so that we can be more clear about that and so that we can actually implement that more effectively. Now, we came upon that actually by accident because we were trying to figure out how, so the kind of traditional way to train up an AI system is just throw a whole bunch of data at it. So if you're trying to train an AI to learn your moral values, and the approach would be throw as much data at it as possible. But how could you ever get the right kind of data? And how that's just not practical if you're trying to learn a specific person's or specific community's moral values. So one of the ideas we had was, well, what if we could have kind of a collaborative effort between the AI model and the stakeholder or the user or the community, such that the AI uses, I'll use this term, we can talk about what it means, but a combination of active learning, which is a type of machine learning where it focuses on questions that are most informative to the model. So it asks you the types of questions that would help the model best understand what your moral values are. And then we combine that with what we'll call interpretable or explainable AI, such that the AI will kind of ask you a bunch of questions. It can either be in natural language or it can kind of give you some scenarios that are specifically designed to be hard for you so that the model can figure out what you would do in these hard situations. But then because we use explainable and interpretable AI, once it says, okay, I think I have a pretty good idea of what your model probably is, it will then tell you about it. And it'll say, here's how I think, here are the things that I think are morally important to you, and here's how I think you're making decisions. Does that seem right? And if not, it's not just a yes or no question. Tell me and fix it. You can actually impact the model and you can actually change the model itself. And it's kind of this iterative process. So we did that because we thought it would be the most efficient way and practical way to train up these AI systems. And it turns out that's probably the case. And I think that'll be the future for a lot of these systems. What we didn't realize until we actually started interacting with them ourselves is that it actually ends up being like a little moral mini philosophy class for you as the human. And I've been studying moral philosophy and moral judgment for decades, and it still taught me things I didn't know about my own moral judgment. And so now I'm really enthusiastic and excited about this kind of this endeavor of using AI as a way to give you a safe place to learn what you think is morally right or wrong, to make mistakes, to go back and correct your thinking, to practice on a regular basis. And that's the first use case. But then the second use case, and this is the one we did foresee and we have grant funding for, is once you have a model trained up in that way, as long as you're using explainable, interpretable AI so that it can tell you, here's the way I think you're making decisions, here's the model I think you have, is that right? Do you feel comfortable with this model, the way we've explained it and what it looks like? Once you say, yeah, I trust you, you got me. This is how I want to make the moral judgments. Now that AI can be used as what we affectionately and tongue-in-cheek call a moral GPS. So you train that up over time. When you're calm and rested, you can fix things, you can correct things. But then when you're under pressure or you're under different incentives, it can then tell you what your calm and rested self said you would have wanted to do in that situation. And not just that, but why and how, and explain it to you. And so we actually have been developing this in medical cases. In particular, we work on organ exchange and organ allocation. And so AI is already being used to help organs be allocated as efficiently as possible. What we've been working on is, first of all, it turns out that there are many ethical considerations that are not always taken into consideration in kind of these, not just AI systems, but medical transplant systems. So what if you did take those into consideration? How could the AI do that? But now what we've learned through working on this with surgeons is, you often will have to make a decision about whether you're going to take a suboptimal organ for your patient, or you're going to let it go and hope that a better one comes along. That's a type of decision that will often happen. That's a moral decision. And you might think, and we might hope that all of us surgeons and doctors and people who have been trained will make that optimally. And sometimes we do. But there's also a lot of evidence that, for example, doctors are much more likely to reject organs or available kidneys on the weekends than during the week. And you can imagine why that might be the case. And you might imagine, well, there are medical considerations, right? Well, yes, but not that one. They can't possibly explain the level of bias we see with people rejecting kidneys more on the weekends. Also, people are much more likely to reject kidneys from African American women than from any other demographic group in a way that can't possibly be explained, and people have tried with any medical explanation. So it suggests that there's kind of this human biases in our own decision making. And if you could have this kind of moral GPS that tells you, hey, look, these are the values you said you wanted. Here's what you said you thought was equitable and fair, for example. That's not the only moral consideration. Here's how you would have calculated that, given what you told us before. That doesn't seem consistent with the decision you're making. Do you want to reconsider? Also, since we've been learning with you, here's one of the things that might be influencing your decision right now. So it's still up to you to make the decision, but the AI might be able to help you do that. So I'll just use that to close out. These are the types of things that when we start talking about, I think some of the things we're going to talk about are what do we need to do in a medical system to make sure AI is used equitable and fairly. Yes, we need to focus on the algorithms themselves, but we also need to focus on the human decision makers. And I think AI can be part of that equation as well, but it's going to be different AI systems than ones that just try to, for example, make sure an algorithm is fair.
Yeah. So I've been here at Duke for just over 10 years now, and in addition to my own research type work, during that time, I've also worked really closely with Duke Health System. And a lot of that role has been how do we develop, implement, evaluate, thank you. How do we develop, implement, and evaluate clinical decision support? So a lot of my interest is in the really practical nitty-gritty side of health AI. Not, I leave all the fancy algorithms to people like Eric and others who, how do we develop the tools and much more about how do we actually get them into practice and into the environment. And what you'll find is that people who work within the health AI, health data science space, but within this space, what they tend to be interested in is maybe around the questions of the algorithms themselves and how do we create optimal algorithms, or maybe it's questions of the substance or the clinical care, what is the right use case for an organ transplant system or for an ICU type system. What I tend to be interested in is actually neither of those things, but primarily I tend to find most health use cases of interest and importance, and I tend to be very agnostic when it comes to which algorithms I want to use. But what really motivates me when thinking about how do we actually get the algorithms to practice, the thing about them are the underlying data themselves. So a lot of the work that we think about in my group and kind of translate back is what are the data that are actually used to train and learn these decision support. So early in my career, I actually worked in a completely different area. I worked in statistical genetics and got really fascinated by just genetic data and the complex structures. And then at some point during my postdoc, someone handed me an EHR data set and I was like, oh, this is interesting. This is, genetic data, if you work with it, can be a lot of zeros and ones that don't change over time. They get boring after a while. I was like, oh, here's data that changes over time. This is kind of fun to play with. Let's see what happens. And, 12, 13 years later, we're still playing with the same types of data. And trying to figure out, well, what are the amazing opportunities with these data, but what are the challenges? So for those, I think at this point, so I remember I started talking about EHRs 10 years ago. You kind of asked people, some people had some familiarity. I think at this point, everyone knows what an EHR, an electronic health record is. Everyone has interacted with their doctor, and everyone has recognized that their doctor spends more time looking at a computer screen than that they spend looking at them. And that has now become a fact of life for bad, but also for good. And I'm not someone who kind of maligns EHRs when maybe someone has to interact with them professionally will. But from a data standpoint, there's a lot of amazing opportunities that come with the EHR. And what comes with it is a consolidation organization of what has happened to you over your health life. So in particular, a lot of my work I do is in pediatrics and with kids. And so here at Duke, for example, we have kids who are we have moms who get their prenatal care here at Duke. We can see information that happens to mom prenatally. We have then baby is born here at Duke. We can see information about that baby that is born here and what kind, do they have to go into the NICU, for example. And we can see them as they develop, and we can see them as they have their well child visits, and maybe they don't have their well child visits, as they get their vaccines, as they develop ear infections, they get diagnosed with different conditions, they develop asthma, this and that. And it's this amazing longitudinal record of what's happening for health. And this is all being collected, this is all being organized for free. right? For free to us, right? Other people are paying for the system, but these are data that are just inherently available. And and this was actually the excitement of EHRs when I first got into the area, and other people started getting into this about 8-10 years ago. Was like, look at this amazing treasure trove of data. These data are just available. All these amazing things to do with it. I like to joke that over the course of a day, I can be talking about cardiology, diabetes, and cancer, and pediatrics, and all these things because I have all these different data sets available. I don't need to go out and sample people. I don't need to do all this work to find people. And in fact, I even know who my population is. My population is often Durham County. I did some really nice work with a demography student here at Duke, where she actually looked at what is the coverage of Duke Health System with regard to Durham County, and estimated about 86% of kids who live in Durham County get their primary care here at Duke. The kids who have leakage are not surprisingly in the southwest corner of the county, because they're probably going to UNC for care. But we can actually talk about populations. We can talk about public health. So one thing I always like to emphasize is that my master's was actually in MPH, which again is always kind of a rod to kind of steer me back to these questions of health. What we started to learn, so I'd say the first 5 years of EHR was this amazing excitement about what are these data, all these things we can do with it. And in particular was that we can develop algorithms and we can develop tools and we can learn some things that are actually relevant to clinical care. That all these great models that were maybe developed from either large clinical trials or large cohort studies that were maybe causally correct, were not translating well to clinical practice. And one of the reasons they weren't translating to clinical practice was because the information that was being used in the context in which the data were being collected were not representative of the way people were actually getting care. And if you want to actually have a model or a tool, an AI that can operate in a real world setting, you need to learn it on data that is representative of that real world setting. And there needs to be some degree of translation, because if you say this is the right biomarker to indicate this, but that biomarker is never collected in clinical practice, it's not useful. Or if only certain markers are being collected within a certain context, again, it's not being represented. So for me, there's always been this great excitement that we can collect data on patients, particularly here at Duke, and we can say that these are data that are representative of the way your patients receive care. And you can provide feedback on what will likely be their outcomes in these various contexts. So that was kind of the initial phase of excitement. And then what started to realize was that, oh, wait, there's also a problem in these data, right? That it's, so I don't like talking about the fact that about algorithms being biased. I actually hate the term algorithmic bias, because the algorithms to me are not biased. The data are biased, and the data are where the challenges arise. And in particular, if the way in which healthcare is delivered or the way in which healthcare is received is biased, that will get perpetuated into the models and the algorithms that you use. So we know that, for example, if a man and a woman both arrive at the ED with similar symptoms, the man is more likely to get a cardiology workup, while the woman is more likely to get discharged. We know that certain scanning tools perform differentially on different ethnic groups. So these are things that we've known for a long time. These are things we've also learned, that the underlying data through which we're learning our algorithms are problematic. And even more so, and some is even more subtle than that, we also know the way people go and seek healthcare behavior is problematic. I like to joke that in my neighborhood, I live next door to a pediatric doctor, and a door down from her is a hospitalist, and 2 doors down from her is an ED doc. I do not go to the doctors. When my kids have a problem, I go to my neighbors, because I don't want to go to the ED. I don't want to deal with that. So all that information that is reflective of their care is actually not being captured because of the condition in which I live, because of the neighborhood in which I live. And so we actually have different capture of information on different types of people. So as we start thinking about, well, how do we then solve this, right? I kind of just started with this is this amazing opportunity. We have all these data. It's reflective of real care. Is it going to solve all the problems? But with the data in which it's generated in the real world is inherently problematic. And if you just throw those data at an algorithm, you just throw those data at an AI, the AI will learn that. And then this has been shown over and over again. I think most people are probably familiar with examples like the Obermeyer example and other examples that have shown that data will just learn and perpetuate biases. And so the challenge that we need to start thinking about is, what are the data itself? What are the data that we are actually incorporating into our tools? What are the samples that we actually are using? Do we actually want to include all people into our algorithms, or do we want to say this subset is actually a biased representation of it, and we want to do this another way? Do we need to be bringing in secondary information, right? Is the EHR itself sufficient, or do we need to link in additional contextual information that can give us greater understanding, not relying on the fact that, race, yes, it is a marker for low SES, but maybe we actually need to bring in real SES information so we could truly understand social determinants of health and truly build those into our models and bring in external information. So, I'll pause there, but a lot of what I like to think about is, what are the data that are feeding our algorithms, and then how do we use that to understand the quality of the algorithms that come about?
I'm Michael Carey. I'm an associate professor in the Duke University School of Nursing. I'm also the AI Health Equity Scholar for the health system. I'm clinically trained as a nurse, but my scientific training is as that of a health services researcher and applied health data scientist. And so I spend a lot of time, because I'm passionate about eliminating health and healthcare disparities. And we use a lot of tools such as advanced statistical methods and AI tools to sort of predict who's at greatest risk for adverse outcomes, such as hospital readmission, mortality, and functional decline. Probably over the last 5 years or so, we've been particularly sensitive to the bias that exists within these algorithms, and trying to study ways of not only how to identify them, but more importantly, how to mitigate them and how to go about it in a systematic way. And so I always like to share this slide here, and this is the study that Ben was talking about previously, about the Obermeyer study. That really was one of the earlier studies that helped sort of quantify the harms of algorithms when they're biased. And so here in 2019, Obermeyer and colleagues was studying data from a large insurance company. And the idea was they wanted to identify folks who were at risk for or who needed intense care management services. And they found that despite the fact that Black patients were sicker than their white counterparts, they were being systematically excluded from these care management services. And when the bias was removed from that algorithm, the percentage of those Black patients who could access those services went from 17% to 46%. And so, like I said, I like to share that example oftentimes because it was one of the early examples of how bias in algorithms is so particularly important to study and mitigate. A couple years ago, the Department of Health and Human Services recognized that bias was a particular problem and that it was widespread. And so they proposed a rule in summer of 22 that suggested that covered entities or health systems and health payers needed to take steps to reduce any kind of discrimination in algorithms based on race, color, national origin, sex, age, and disability. And this really provided a jumping off point for our research team, because the problem with this was they really didn't specify how to go about identifying or correcting the bias that exists. And so we started to develop a scoping review, and I'll show you a little bit about that in the next slide. But I wanted to just share this picture with you because at the health system, we recognize that bias is a particular problem that we need to study and we need to mitigate at all times. And I share this with you just because you can see here that this is a pretty large group of individuals, all dedicated to ensuring that AI tools within the health system are safe and that they're compliant with regulations, and that they are reducing, or that we're reducing bias that exists within these algorithms. And you can see that because the complexity of these problems are so challenging. No one discipline actually has the domain knowledge to really figure this out by themselves. So this is a large team of clinicians, health services researchers, folks with legal backgrounds, data scientists, and folks with operational backgrounds, really sort of wrestling with these topics every day. My particular role is to think about where the bias exists across the algorithm lifecycle, from development to evaluation to deployment. And as I said, one of the earlier things that we wanted to do was to get a really good handle on all the different types of bias mitigation strategies that exist, and to use that information in informing the practices that we use to evaluate algorithms within the health system. So a couple of years ago, we conducted this scope and review, and we had about 109 articles, including frameworks, review papers, perspectives, and applied healthcare applications, all of them looking for ways in which the field is mitigating racial and ethnic bias with these algorithms. And we came up with a lot of different strategies that we were able to publish in Health Affairs, but I'll share with you just in closing the call to action for building equitable and responsive AI. So we came up with 7 of these strategies, and one of which is to establish governance structures. Another one is to enhance workforce development and professional diversity. Among the 109 studies that we included in our scoping review, there wasn't much representation of healthcare professionals outside of medicine or outside of data scientists, which is particularly problematic. Another thing that we wanted to recommend is to require auditable clinical algorithms, as well as fostering transparent culture. This one is particularly important for me, is to implement health equity by design. And what we mean by that is that health equity shouldn't be an outcome. It should be the way we think about the designing of these algorithms from the very beginning, all the way through the algorithm lifecycle. Accelerating research goes without saying. And lastly, amplifying patient and community voices. And I think some of the panel already spoke about some of the importance for that. So with that being said, I'll close there and we'll start. Go ahead.
Thanks for such great talks. As I mentioned, we'd love to hear questions from the audience, but while you're, and just feel free to raise your hand and say them out loud and we can repeat them for the recording. But while you're thinking of questions, I wanted to start with a question for Jana. That was a really fascinating talk. And I wondered a little bit, it seems like in the work that you do, the best case scenario would be that there is a clear normative standard, but that is not often the case. And I think especially in recent years, we've seen that social norms shift. There's increasing polarization. And so how do you think about those sorts of things when you're developing tools, when there's not sort of one size that may fit all clinical scenarios?
A great question. So there's kind of a cop-out answer, which I'll start with, and then there's the harder answer. So the cop-out answer is when you're trying to develop tools, that you try to develop tools that can account for that or that allow flexibility, basically. So one way to do that is, okay, we say that we know that many people have many different opinions. First, you have to help them actually figure out what their opinions are. You have to have that be translated to you in a way that they can verify. And then you have to be able to mathematically translate that. But then you can also build in systems or ways into your system where you can have different voting techniques, for example. So you have these different people's opinions. So here are different voting schemes we can use to aggregate them into, say, a system recommendation. And you can think of that as kind of, we borrow on ideas of democracy. So there are different ways, different types of voting that are used in democracies, and you can actually use mathematical algorithms that do that. And you can actually and you can build in ways to have a community kind of vote on how much weight should, say, certain experts have, should certain groups have. Do we need to amplify some voices over others? And so we say, we're not going to decide that for you, but we're going to give you mechanisms. And we're going to kind of propose different ways you might want to think about aggregating different people's decisions. So that's kind of the cop-out answer. It's only a cop-out in that I'm not answering the hard question, which is how do we actually figure out what is right or wrong to do in a given situation? And that's a much harder question, of course. And here I will I'll open up a big can of worms and then I'll shut it real quickly. But one of the things I really had to think about, because I really tried to introduce kind of how my interactions with AI and how I do it at all of these different levels. And I really try to think as a researcher, but also as thinking about my students who are going to go out there and be implementing an LLM at Facebook. What are the pressures that they're going to have? And those are in many ways going to impact people's lives more than the AI we're working on here at Duke, as hard as that is for us. So what is it that we need to do as a society to get to the point where people feel better about kind of the moral direction we have? And so here's the can of worms that I'm going to throw down the table and then close and then kind of connect it. But I think that we really need to try to get to a place where we think of moral learning. People have heard of the idea of a growth mindset in other contexts where you're not just smart or not. If you work hard, you can learn things. And anyone can learn things. Well, the same is also true of learning how to be moral. What you think is moral. That it's not your good or your bad. And we're kind of in a society now where that's threatened all the time. And it also means there's a psychology as humans have, which is that because our moral identity is kind of the thing that we care about most, that if we're threatened and we think you're going to tell me that I'm morally wrong, I'm going to shut off my ears and I'm going to fight like hell to make sure that that is not the case and that I convince myself that's not the case. So we're kind of in a culture right now where none of us can learn and we're all scared of being labeled as being immoral. And so we're going to have to work on that. That's the can of worms I'm saying. We're going to have to work on how to change that at all levels, whether it be on the workplace, whether it be at home, whether it be kind of in social media. And that's going to be a critical prerequisite to even get to the place where if you're working on a single system in a healthcare setting, you can figure out what's the right and wrong system. The other piece then kind of connecting that is, I think we can't think that there is a right way. There are just ways that are better than other ways. And we might look back on it and we might say, we should have done that differently. But that doesn't mean we shouldn't do anything. And that doesn't mean we shouldn't make efforts to do something that's more right than less right. And so that's the main thing, is not think there isn't one right way. There isn't one objective. We're just trying to do better as best as we can, knowing we're probably going to make mistakes and we're going to need to constantly make progress. That's how I see it.
Excellent. Thank you. And I'd like to extend the question to Ben and Michael too. So when you think about promoting equity in clinical settings, sort of an extension of Jana's question, how do you even define that? What's the right metric to define equity? Is it sort of that patients have equal opportunity to achieve health? Is it that they have equal access to resources? Or maybe it's not about having equal access. It's sort of about having access to resources that they need to promote health. So how do you go about determining how equity is even defined when AI is implemented in the health system?
So I don't know if folks have seen it, but there's a wonderful infographic. It's off the Giving Tree, the old Schultz Overstein book, that kind of, it illustrates, the notion of justice and equity, kind of basically how different people can, two different kids on two sides of an apple tree can access the apple tree, and whether you make the apple tree such that, you have a shorter kid and you give that one like a higher ladder versus, that would be, equity versus equality. If you give them both the same ladder, only one can get it. So, to me, when it comes down to, I think a lot of what Jenna's talking about, right? It's what you value. And I think that, and to me, that's a really hard conversation to have. Michael and I worked on a paper a year or so ago about this question. The big question right now in health space is, should you put race into your laws? That is kind of, that's been the question for a while, is, should race be in algorithmic models? And there are people who say, no, it absolutely should not, because there's no biological basis how race impacts most diseases, and that is generally speaking true. There are other people on the other side of the fence who will say, no, it quantitatively makes algorithms worse not to incorporate this into your tool for a whole variety of reasons that I don't want to get into right now. And where we came down, at least where I came down on this, is that it's not a black or white question, right? It's you need to just have the conversation. You need to have and what we wrote in this was that if you're going to include race in your model, you want to have an open conversation about why. What is it serving as? What is the function that it's serving? Is it because you actually think there's a biological basis? Is it serving because it's serving as a marker for social determinants of health that are otherwise lacking in your data. Why is it in there? And ideally, you would do that for almost every variable in your model. You're not, but particularly for these more, what have been termed now sensitive variables in the field, race, sex, other factors that are not necessarily biologically driving factors, but we know are related to health. It's an important and tough conversation to have. So that kind of ties back. Well, how do we think about these issues? I think that we need to be able to engage in these hard conversations. I remember when I first got into this field, the first tool that I developed here at Duke, we developed a model, we just handed it off, and we said, here's the probabilities, and I said, I'm done. I didn't want anything to do with the efforts. I said, I'm not a clinician. I can't make a decision, right? I'm not trained to do that. That's not my responsibility. I wanted to hand it off. And the nurses hated the tool. They absolutely hated it. They did not, because all they got was a number. They didn't know how to interact with it. They didn't know how to interpret it. And what I realized was that I was the only one who actually understood the numbers. Right? I understood what it meant to say that a person had a 2% probability of dying in the next 12 hours, which is what the tool is predicting. 2% actually is a very high probability of dying in the next 12 hours if you're in the hospital, because these are this predict high-risk patients, and that it was actually my moral responsibility, if you will, to be engaged in that decision-making process and to help contextualize and inform. And so one of the things that we actually have conversations about with tools we develop is particularly when it's a decision support, is don't tell me about the right decisions, tell me about the mistakes you're comfortable making. So I'll ask a doctor, would you rather overprescribe or underprescribe? And there's context for both. Would you rather overdiagnose or underdiagnose? Because once you tell me about the mistakes because once you make a decision, you are making a mistake. I can even tell you at what rate you will make that mistake. I can't tell you for whom. I can tell you for this many 100 people, you will make a mistake this many times. So tell me about the rate at which tell me about how often you're comfortable with mistake, the kind of mistake you want to make. We developed tools during COVID. We made mistakes that were more conservative because we were concerned about certain aspects. And then we can start talking about what that means as we go into practice. We start having those moral conversations about where do we want to balance things out. But that's something that I think the perspective I've gained the most from being on the implementation side is the importance of data scientists being engaged with the end user is so paramount, because we understand the algorithms to a degree that you just can't expect a nurse and user to be able to appreciate.
And I'll add to that. I think you were probably the first one I've heard last year at the symposium when you said that data scientists are now part of the healthcare delivery team, which is true. So I would say, so Bill was describing a little bit about the really robust conversations that we had as part of our governance oversight committee when we are evaluating tools that are sort of progressing through the system at different stages. And we're having these conversations amongst ourselves about the rationale to include race or any other sensitive variable. And then we're having a conversation with the clinical team and the development team as well to give us rationale and provide us with the results and to explain differences based on model performance. And so those conversations are so enlightening and helpful because we are all looking at the same problem with a different lens in training. And so that helps us to sort of make informed decisions. I'll go back to your comment about equity and equality and trying to measure those challenging concepts. And so what I find oftentimes is that people use equity and equality and conflict the two, right? So equity is not equality. Equality is that, okay, you get an apple and you get an apple. And that's not equity. That's equality. And so equity means is that you are giving an individual the opportunity to achieve optimal health. And so that may mean different resources. And how it relates, how we are trying to define it is through identifying bias and identifying disparities in outcomes and reducing that gap between those outcomes.
Questions from the audience? Otherwise, I'll keep going. Yeah, Eric.
Hi, I'm Eric Munson. I work in the libraries. I don't know, this isn't a super well formulated question, but one of the things I've been worrying about with AI proliferation is the unexplainability of so many of the really capable models. And hearing explainability come up in so many of your comments, I'm wondering do you think the health system and the care delivery stuff is actually going to be a big driver for development of explainable AI? Because I'm just worried that so much money in unexplainable stuff is always going to win. Is this going to be a driver towards explainability in those systems?
Say something about that. Yeah, so maybe I'll say one thing just to add in the previous discussion, which is the things we've been talking about so far have been focused on decision support, decision like informing decisions. So how do we give you information to help you make the best decision, whether it's speaking about morality or about treatment options or what's worked for who in the past. But there's also this risk with these bigger models where you are no longer supporting but are making decisions. And that's when things get really sort of scary potentially, right? Because there's no human in the loop to say this situation is not appropriate to give this treatment. Right? So in terms of explainable AI, there are laws in some parts of the world where you do need to, if you're making a decision in a healthcare system that's using a model, you have to be able to explain why it's doing what it's doing. Banking is feeling more pressure along these lines. If I deny you a credit card, right, I have to tell you why I did that. And that's not always an easy answer, right? If there's 15 variables that go in, and that's not even a very big number, right? And they all go into some threshold, and then they say, if you're above the threshold, you get the credit card. And if it's not, you don't. So why didn't you get the credit card? Well, is it because your FICO score was too low, or because your credit risk exposure was? Any of those things could have moved, and you would have gone over the line, right? And so how do you convey that information to somebody in a way that actually means anything to them, right? And it gives them change. So I think, so one thing is, it's really hard to explain these things, even simple models. Take a linear model, right? Just add up some scores and you get a number, but what put you on the line? What needs to move, right? So that, even that is not explainable, right? So I think that's hard. And then I think, people try to do things like, well, because people who were like you, whatever that means, did well on this treatment, or people who were like you didn't pay their credit cards off, so we didn't give it to you, right? That may not be satisfying either, I think. And so, having it be, and then there's this other piece, sorry, I don't want to ramble on here, but if it was going to tell you something you already knew, then what's its purpose, right? So there's this other problem that happens when you test AI systems. You show it to an expert and they go, oh yeah, that's what I would have done. This thing's great, right? Well, then what was the point? You were going to do it anyway. So, and then if it says, oh, I wouldn't have done that, something's wrong with your tool, how do we evaluate these things as humans, right? It sort of loses either way somehow. And I think that's another evaluation problem. And so what you have to end up doing is really testing these systems and seeing empirically where they do well. So you like the decision that it recommended based on your expertise, and then you put it into practice, but then you look at other outcomes and you say, actually, it's somehow empirically works anyway. And then you dig in why. So I don't know if others have.
I'm not going to have a very optimistic answer. I don't think it's going to have much of an impact. I think the pressures and incentives for building the big foundation models are so great that medical incentives are not strong enough to influence them. So it's not that they don't care. Also, it's not that people who are building the systems don't care, but there's just too many incentives. So I could pontificate and give you ideas of how I think it would be great if things, proceeded, or how it could proceed, but that's probably not what you're asking. So unfortunately, I have a pessimistic answer.
An answer that's maybe not different, but maybe less, maybe even more pessimistic, I don't know, is I would say there's a lot in medical care that's unexplainable. I don't think most doctors can explain how an MRI machine works. I think it's like high level, right? Some magnet kind of spinning around, but, if you have to really kind of break down, right, how is it showing that image of the brain or whatnot, right? Why is it doing it in that way? I'm going to venture that the average doctor who's looking at it can't, won't understand it. Even, and I think maybe how blood pressure cuff works, but maybe even, I don't know. I don't know how blood pressure cuff works. It's felt kind of magical too. But so I actually really do like the term that's come up, which is software as a medical device. That's kind of how the government and Michael was alluding to it, kind of the regulations are coming to this notion of SAD. And I think there's a lot of value there because these are becoming medical devices, for good or for bad, right? But it's something that as we think about, these are things that are being integrated into clinical care, and they are providing a good shot. I think Erica is exactly right that when the decisions are being made solely off of that's when things can become a little bit challenging. But as a way of providing additional medical understanding of medical insight and result to a patient, then I think what we're going to find is that we're kind of in this weird transitional space where no one quite knows how to integrate these tools into their routine care. But we're going to have a generation of doctors who are growing up interacting with these tools and are developing their medical intuition alongside these tools on a day-to-day basis. And definitely what is happening, medical education is going to need to, in the same way, give a seminar on how blood pressure cuffs work and how MRI machines work. They are focusing more on how does machine learning work. So you have enough of an understanding to understand how to incorporate it into your result. So I can look at an algorithm and say, this is what it's telling me. These are the important factors that are driving it. And this is actually, but I know, for example, that this algorithm knows nothing about that. It doesn't know the fact that this patient is living in this type of social context. And that's probably what's missing. And I can understand that's what's missing here. But therefore, I'm going to override the recommendation or kind of go for a different recommendation. So I think right now it's a challenging time. But I think we'll get a high level explainability, right? This was an important variable or this how it's driving things, but we're not going to know why that decision was made. But I think in a way that will help inform a broader decision making.
A follow-up question then about transparency. So you're saying that software is a medical device, right? So patients have to consent to the use of other medical devices. And should that be the case where AI is concerned? So for example, in the setting where I practice in the ICU, there are tools that tell me how likely a patient is to die, which could have profound impacts for how I treat them. Should a patient have to consent to me using that sort of tool? That's sort of hypothetical example because it's not really used in practice in current day, but I'll give you another very benign seeming example, which is that we heard this week that ambient listening is now live at Duke. So when you go to see a Duke clinician, there's an AI that will sort of be listening to your encounter and creating the note for the clinician to edit, which as a clinician, very excited about this because it'll really reduce the administrative burden of writing notes, but there's a lot of sensitive conversations that happen, right? And as medical care is increasingly politicized, if we're thinking about things like abortion care, transgender health, et cetera, organ transplantation being another good example, should patients have to consent to the use of these sorts of things in their care?
I'm not going to answer the ethical question because I've heard that question posed as well. But just off the ambient listening, so I was chatting with, speaking about the quality of data, I was chatting with folks in psychiatry, and they said that for years, that the quality of the notes in psychiatry is actually lower because psychiatrists are aware that these notes are actually being looked at and analyzed, and that they may go back to, and that now that they're going back to patients, they're actually documenting a lot less. So I do think that, as I mentioned, right, what I think about are the quality of the data. I think exactly what you're saying. In these sensitive environments, the nature of the data are actually just going to change and evolve. And it's something that people, as our future selves who are learning tools off of these data that are now being adapted in a real world environment are going to need to be highly cognizant of that. But I'll leave some of the ethical questions to the moral philosopher.
So I'm not the moral philosopher. I'm a neuroscientist. That's why I wrote a book with the philosophers, for the record. But I will say what I was going to say. I'm not going to answer, yes, I think they should have consent. So I am one of the rare people who still thinks privacy is really important, but I seem to be a dying breed. So I'm happy to go on that soapbox, but I'll just put that out there. But I just want to mention that the example you just gave is a perfect example. This is part of the things that we try to talk about in our book, are how many different ways that an AI can lead to bias that have nothing to do with the algorithm itself. So certain demographic groups trust technology a lot less. Right? And if they know that, and they have good reason for that, because technology has not benefited them to the same degree it has been used against them. So there are going to be certain demographic groups that really need help that will be less likely to come get medical care if they know that they're being listened into. Right? And so it's just one of many ways that when you're implementing an AI system, there's so many things to think about that have nothing to do with the algorithm itself. Also the algorithm. And I work on the technology, but there's so many other factors. So I just wanted to mention that as an example.
And I think I'll just chime in to say that I think that we're having a lot of discussions now about how we go beyond thinking about the technological performance and the safety to building greater trust with patients. And that does center on informed consent. And I think that there's just Suresh just sent the paper out last week that was really good by a group out of Vanderbilt, by Rose and Shapiro. And it talks about a framework that helps us to kind of categorize patient engagement and informed consent based on several categories. One of which is the tool patient facing, or is it not? So, for example, if you're using the electronic health record, does that person have to be informed? Because that is working sort of in the background, but versus a chatbot where that patient is interacting with, then how that technology is being used to inform care should be an informed consent process. Another category is clinical risk. There's very little clinical risk for AI tools that are necessarily trying to inform bed allocation, things like that, versus other tools that are more life altering and that absolutely need informed consent. So I think that we're at a point where we're trying to figure out how to categorize and how to sort of help us understand where informed consent is needed and where it is not, and engage with our patients.
Is it okay if we do like a closing? So, okay. Yeah. Any other questions from the audience? And maybe one last one. Yes.
Thank you. Jesse Optikar with Foundation Relations. I'm curious recently with the passage of the Physicians Make Decisions Act in California, that is prohibiting the use of AI in coverage decisions. How do you see kind of public sentiment potentially impeding, the adoption of AI in healthcare, if you have any perspective on that?
I'm not familiar with the act. So you're saying that AI can't be used to make insurance coverage decisions. Is that the gotcha? Yeah, I mean, I think, like Jenna was saying earlier, I think we have to remember that a lot of the ways that AI is being used, sort of like what's the current state? So the current state is that lots of people are making moral decisions, and that process is not transparent. The current state of insurance coverage is that human beings are making decisions, often without content knowledge of the patient's condition based on flow charts. So, I don't know that that's so much worse than what we're doing currently. So that's what my perspective on it would be, is that I think there are lots of founded concerns about, the use of AI and these sorts of things. But I think we also have to remember that currently we're using human judgment, which may not be the superior alternative in many cases either.
I mean, to give a positive side of AI, it's very easy to knock AI is the bias of it. I think the positive side of it is exactly what you were getting out of it, which is, AI is at the end of the day an auditable system. So you can actually, and it's a consistent system, right? You may be biased, but to be consistently biased, right? That's actually a good quality, right? Because it means that you can look at it, you can learn from it, and you can adapt it if you find that it's making a mistake. The problem, the challenge with humans is that they're not audible, right? You can't, if someone made a decision to deny or accept coverage for something, you can't go back and say, well, why was that actually made? To use the organ transplant example, an AI will never make a decision to say, it's Saturday night. I really don't want to get out of bed right now. I'm going to say this organ is not good enough. Whether that organ comes on 2 p.m. on a Wednesday or 2 a.m. on a Saturday, it'll make the exact same decision about the quality of that organ. And if it does, and if it makes a poor decision, we can go back and learn from it. And we know that it'll make mistakes, and we know the rates at which it'll make mistakes. I can't go to a doctor and say, so you're a doctor that makes a mistake at a 3% rate. You're a doctor that makes a mistake at a 5% rate. I'm going to go to this doctor. We can actually do that with AI, right? You can say this AI makes a mistake at this rate of this type. So I think, I think it's super important to be cognizant of the challenges of the biases. But at the end of the day, I actually have a lot of hope and faith in the consistency and ultimately the objectivity of the tools, as long, and the fact that we can improve, that there is our means to learn where they were wrong and then improve upon them in a way that we just can't do with humans.
The only thing I'll add, I don't disagree with any of those things, but I'll actually tie it back to what you said earlier. And this is also something I try to teach my data science students. And data science is a product. So you can make whatever model you want, but if your user won't use it or believe it or trust it, it does not matter what your model is. And so I think that the whole AI community has to grapple with that right now. So of course, there's going to be pushback, and there's also going to be excitement, and it's going to take a long time to work out. And I think part of what those who are enthusiastic about what AI has to offer need to do is get dirty and start talking to the end user, because I have one of my lab mates started Google Brain, actually. And his big statement that he always says is AI only moves at the rate of trust. And that's been a hard thing for him to learn. And it says that it all boils down to that. And so if we can't, I can't say it more succinctly than that. So it does not matter how good our AI systems are and if they make our decisions better or worse. If end users don't trust them, they're not going to have the end goal we want. And I still am one of these people. That's why I'm the neuroscientist, perhaps not the computer scientist, but I still think people are the end goal. And so impacting their lives is the end goal. And so to me, that should determine whether we consider it successful or not, whether the algorithm in theory can lead to better outcomes, whether it does lead to better outcomes.
I mean, I think this law reflects maybe a wide perception that it's got to be one or the other. I mean, AI is great at automating very easy decisions. So just simply getting rid of the decisions that are trivial so that humans can focus on the tough cases is such a benefit to everyone, right? So even it's an all or nothing type law is guided because people think this.
Thank you guys so much for a great panel. I guess in the last 3 minutes, we'll close. I wanted to ask each of you, what are, when we're thinking about AI being used to promote health equity, what's sort of your biggest fear in the coming years? And then what is the thing that you're most excited about?
I don't know what my biggest fear is. But one thing I wanted to sort of get to today, I didn't really come up very much, is just how much I think healthcare can learn from tech companies in terms of delivering things at scale that people will use, which is such a hard thing to do because you have to build the thing right. You have to build it in a way that they want to use it and will use it, and then will make the impact that you're trying to make. And so they're investing not only in how do we solve hard science problems and hard medical problems, but how do we actually build the tools in the right way and put all the other resources in engineering and UI UX and customers sort of study to build it, and not based on this should work, this is a good idea, so we'll build it and then see what happens, and then it sort of falls flat. So I think science and medical research needs to embrace that it's going to cost a lot, and it's going to take a lot of investment that's not necessarily science or medical, but everything else in order to make the kinds of impactful changes we've seen in other parts of science and society.
I don't know if I can come up with one for either one of those categories. I mean, there's so many things I'm excited about AI and medicine and science and drug discovery, diagnostic potential. I mean, there's just it's endless. So there's so many things I'm enthusiastic about. I also don't know if there's only one fear I could choose. I'll tell you one thing that I'm thinking about a lot right now, though. And I didn't mention, so I've been talking about the moral AI work, but I mentioned briefly that I also work on social connection. And what makes us feel socially connected. So there's a lot of evidence that the more socially connected we feel, the more resilient we are to all kinds of life stressors. And it also carries over to the medical domain. The more socially connected you feel to your healthcare providers, the more health outcomes, better health outcomes across the board. You recover from surgery better, you manage your health better. I mean, just across the board, that's the case. So your sense of connection with your providers really matters, as well as the community around you. And I am thinking a lot about how AI is going to impact that. And I don't know the answer right now. I don't know, especially with these new LLMs, and they get better and better every day. And their social intelligence that I mentioned gets better and better every day. Can we feel socially connected to an AI? I don't know. I'm trying to collect data on that. Do we want certain types of connection from AI or from that's different from what we want from humans? Do we want certain types of connections from humans that we want? I don't know. I'm trying to collect the data on that. But I think the answers to that really matters. Because if we start kind of shoving AI tools down people's throats and replacing kind of some human interactions, even in the healthcare domain, things that we think are not important that take time, like just saying hello or checking up on you after a surgery. If we actually need to feel socially connected during those times, AI is taking the place of a human now, and we can't feel connected, then there are actually going to be dramatic impacts on health across the board. And so that's something I'm thinking about a lot, trying to collect data on, trying to understand from a mechanistic, but also a population level. And I think it's something we all need to be thinking about. In what cases do we need human interaction or human connection? How does AI help that, hurt that? We need to be monitoring these things because it feels like there are few things that matter most to our health overall and to our general life well-being.
I think what's exciting me the most lately in past couple of years has been the fact this is like even happening in health. If you look at the history of health and technology, health has actually been a really conservative field and has been very slow to adopt new technologies. And I think there's actually a lot of interesting reasons. I think COVID had a lot of big play, but health was actually one of the first areas to really jump feet first into a lot of these AI tools, particularly large language models and integrating these tools into healthcare. And I think there's some danger there, but to me, that's ultimately exciting that we're sitting here talking about AI, not in the context of online advertising or not in the context of finance, but in the context of health. And that the people who are working in this space, for the most part, care, right? Yes, there are people who are trying to make a buck out of it, but the people who get into health are not doing it because they want to get rich. They're doing it because they want to improve health. And I don't think you'd be having the same concerns or thought processes around biases and inequity if this was a credit card bureau conversation, which is much more economically. So the fact that health is actually driving this field and that it historically has put equity in the front and center, I think to me it's really exciting. What concerns me, I guess, on the flip side is I do worry where that new clinical gestalt is going to come from. I do, I think they'll figure it out, but health is such a apprenticeship-driven field. So it's so much of your decision-making is being informed by a tool, and you don't have that opportunity to essentially apprentice and make mistakes. And I don't think it's actually just for doctors. I think we're going to see this for data scientists. We're seeing junior data scientist jobs go away. That with the advance of these tools, what's going to happen to junior people to start so that they can start learning and developing and come up in the field. I think it's great for us who are well established in the field, can leverage it. I do worry about the future generation of, how are they going to get their foot in the door if a lot of these foot in the door roles are being taken over by AI.
I guess I'll add that I share the same enthusiasm around the use of AI within healthcare. And I'm particularly excited about regulations that address the potential for bias within algorithms in particular, such as the anti-discrimination rule that I presented earlier. I am concerned, though, how that could potentially exacerbate existing disparities. For example, Duke is very robust in terms of governance structure, and we have resources to study a lot of these phenomena. And we are connected to an academic institution with our health system. But if we go north of here in Granville County or Person County, that infrastructure doesn't exist. So how are they going to implement or benefit from the use of AI as we do? And so I'm concerned about AI in some ways being a great divider, and how do we figure out ensuring that health systems such as that get the needed resources that they require to improve care in those settings. The other thing that I'm particularly concerned about is that there is no existing training within health professional curriculum that prepares professionals on how to use AI responsibly. And I'm working with several individuals, particularly within this room, now trying to figure out how do we upskill and retool next generation clinicians. I think that that needs to be something that we really need to prioritize, like yesterday, because new tools are being developed all the time. And I'm concerned that if this is not prioritized, we'll be on ChatGPT 10 or 11 before we get curriculum built for clinicians and using it within practice.